And so, look, thank you for the introduction, and I'm really delighted to be here. I'm very grateful to the organisers for having me and for having this topic. And this topic combines two things that I really love, and that is respiratory physiology and sport. So I'm going to talk about, there are 5 things to take away, and I flagged those, and if you're taking notes, there are just 5 things to write down, and 3 diagnostic considerations for you, so that you might just have 8 dot points at the end of this, and if you can take those away, then I will have done my job. And this is the first key point. Sport is really important, okay? It's really important for society, and Australia is actually one of very few high-income countries that doesn't have a national strategy on sport. And so how we do sport in Australia is sort of devolved to states and local councils and individual clubs and individuals. That's another story, I suppose. But it's also really important for the individuals. Okay, I'm going to just run through some of just a brief skate over some of the literature about why sport is important for kids. For those who might be looking for some references, I'm going to send those in to be on the Don't Forget the Bubbles blog. And so for those who are seeing the video cast or the listening to the podcast, those should be available for you. And the first is it's sort of extrapolation from the adult literature, and I hope that people are familiar with the fact that exercise has the same efficacy in adults for mental health, for anxiety and depression as antidepressants. Yeah, that shouldn't be news. That's been something known for a while, and so too with adolescents. Participation in exercise has a whole lot of mental health benefits. For those with certain health conditions, ADHD is something that's common in kids, and young teens have been shown to get benefits in the same sort of ballpark as stimulant medication in terms of CNS benefit and cognitive gain. The literature is not as strong as you might expect in terms of participation in sport supporting weight control, but there's at least a mild to moderate benefit. There is significant benefit, however, in terms of metabolic indices. Here's where it starts to get very interesting from my point of view. So participation in sport and fitness actually has medium-term benefits in terms of lung function for kids and for kids with asthma. And you might think, oh, maybe that's just, well, those who have better lung function are going to do more sport. But controlling for that, exercise and fitness improves lung function, and this is where it gets even more interesting, and that benefit is sustained into adulthood. So the more people participate in sport as kids, the better their lung function can be down the track. So here's key point number 2, and this is where we start to get a little bit tricky. Exercise and participation in sport is fantastic. There is no doubt about it for those kids. For us as clinicians prescribing it, it's difficult. Okay, that on the whole, when we prescribe sport for people, there are plenty of anecdotes about, my doctor said that I should get involved in sport, and then that's how I became an Olympic diver or whatever champion. And certainly there are people who have been leaders in their sports who ascribe their participation to a comment that their doctor made. And so there are anecdotes like that. But when people have studied prescription of sport in the adult and teenage literature, the results are actually a little bit disappointing. So you have to do what you can, but the main thing that I want to say here is that you can stuff it up. You can get it wrong, and you can discourage people from participating in sport, and we don't want to see that. In some cultures and in some circles, there is a mythology that kids with chest disease shouldn't actually be participating in sport, and it's okay for them to sit out, and there might be notes written to excuse someone from exercise. Don't want to see any of that. Okay, we actually want the kids to participate in sport, so they get the benefits if they've got a chronic disease or any sort of health issue. We want them to have the same benefits as someone who doesn't have their respiratory concerns. All right, so a question for the audience here. So put up your hand. Who has asthma or had childhood asthma? A smattering. And I would estimate, thank you, I would estimate that you're an appropriate cross-section of the community, depending on how you diagnose it. 10 to 20% of kids get asthma. Next question. For everyone, do you get short of breath when you exercise? Put up your hand. All right. 100% of us should. So shortness of breath is that subjective feeling, or dyspnoea is that subjective feeling of rapid breathing or difficulty of breathing. And we should all get that. That's what cardiopulmonary exercise does. So the next point, key point, shortness of breath on exertion is common. It's so common, we even have an acronym for it. And thank you for laughing at that. So when I wrote that a week ago, I texted a friend who's in another room right now, and I said, I have the funniest line of the whole Don't Forget the Bubbles few days. And I tried it on him, and I got crickets, I got nothing. Anyway, thank you. All right, so I'm going to take you through an approach to a case. And it can be, imagine that it's one of these kids or any other child that you're thinking about. Sometimes the presentation will be, my child has shortness of breath on exercise. Sometimes it will be so-and-so can't participate in sport because of asthma. It's all can be wrapped up in different questions, but you need to think of it as a diagnostic problem of shortness of breath on exertion. And this is how I approach it. So first of all, the diagnostic considerations. Number one, asthma, common, 10 to 20% of kids. Not that it's the cause, but it's common in the community. There's a bunch of other diagnoses that you need to think about and you shouldn't miss. And then the third one is just normal exercise-induced dyspnea or fitness. So with respect to asthma, so you need to sort out, does the child have asthma? If they have asthma, is the shortness of breath on exertion due to that asthma? And then the third bit is, well, if they get shortness of breath on exertion due to asthma, is all of their shortness of breath on exertion due to asthma? And quite often, it's not, and yet we teach the young kids that when they get short of breath, rapid breathing, that's asthma. We should be teaching the young kids that, because that's when they take their salbutamol, and then as they get towards the age of 10 and they start to take a bit more independence and decision making, they haven't actually learnt that shortness of breath is not all due to asthma. So I'll give you a framework for sorting that out in a second. If it's all due to asthma though, or you think it is, firstly, if there's asthma at baseline, you just treat it. Treat the asthma. If their asthma is not well enough controlled, just go further up the sort of step ladder of treatment, give them more treatment. But specific to exercise-induced asthma, of course we use salbutamol. We recommend pre-medicating with salbutamol, not because it's the best treatment, interestingly, because it's not, but everyone has it. They've got salbutamol, they've got their puffers, so you have a couple of puffs before participation in sport, and that should do the trick. And if it doesn't, then the next most potent medications to use, montelukast, that's actually really good, and that can be taken a couple of hours before sport, perhaps in the morning before they head off to school, night before if it's a very early morning game. And if they can't tolerate montelukast, then salmeterol added to an inhaled steroid is the next best choice. Onto the group of conditions that you shouldn't miss. These should be evident on history and examination. So other lung disease, you should be able to nut that one out. Anemia or cardiac conditions can cause shortness of breath, but I can tell you that I've never ordered a full blood count. I've never ordered an echo just as a screening test in this sort of situation. I've relied on history, examination, and special tests, lung function tests, not as a screen to send them off for a test for those things. So you should be able to nut those out in a clinic room. And then we come to the diagnosis of exclusion, which is normal exercise-induced dyspnea or lack of fitness. And this is where the issue of weight comes in a little bit. Kids with excess weight actually do have, well, of course, they're sort of less likely to be fit, but also the extra adiposity on the chest actually contributes to a feeling of greater shortness of breath when that's measured independent of anything else. So it may be that not only are they less fit, but they feel their lack of fitness or feel their shortness of breath ahead of where others might. So they get hit twice. And you can really only do that after you've done these things. You can only come up with that sort of conclusion that there's nothing pathological going on after you've taken a thorough history, done a thorough physical examination, and then done your lung function tests. And at least I can't imagine sorting out this issue without access to lung function tests. So I'm just going to take you through it. This is our old friend, the lung function test. And I can't really double point, can I, with the laser. So the anatomy of a lung function test, the y-axis is flow in litres per second, and the x-axis is volume in litres. And so just call out the answers to these. So what's the top green arrow there? So the bottom part of the graph is the inspiratory loop. The top bit is the expiratory loop. And so the top arrow points to the highest flow or peak expiratory flow rate, peak flow. And the bottom arrow, what would that be pointing to? I think I heard it, vital capacity. Yeah, well done. And then the middle arrow pointing to the mid-expiratory flow rate. Good work. And so we also have some values there. FEV1, which is oftentimes people think that that middle part is something to do with the FEV1, but an FEV1 is derived by the computer or measured by the computer. It's not on that curve. Vital capacity, okay, self-explanatory. Forced expiratory ratio, remember that one? FEV1 over vital capacity, that depending on age should be greater than 75 or 80%. And mid-expiratory flow rate is a value that we get from lung function tests. So I'm going to take you through some of them now. So these are a lung function tests that I've ordered in the last month. So this is one who had likely exercise-induced asthma. So what do you think there? So if we have a look at the graph, and the blue is baseline lung function, and the red is post-salbutamol. Okay, so just looking at the curve, there doesn't seem to be too much difference between the two, does there? And if we go and have a look at the values, the pre or baseline lung function test values are all within the normal range, and there's no change or no significant change after salbutamol. So that's a normal lung function test, and I would say that there's no bronchoconstriction and no improvement after salbutamol. How about this one? Give you a moment to think about it. I can hear a few little comments, so a bit louder so I can hear what you're thinking. What do you think? Beg your pardon? Obstructive picture with a bronchodilator response. All right. So we can see at baseline the blue, all of those values, just looking at the graph, they look sort of in the normal range, but we can see that the curve looks a little bit scalloped out. Okay, so that suggests to me that there's perhaps some reduction in mid-expiratory flow rate, and after salbutamol is administered, then we get the nice straight line. So let's go and have a look at some of the values there. So the FEV1, so baseline values are on the left and then post-bronchodilator on the right. So FEV1, well, in fact, all those values are in the normal range, interestingly. They're all in the normal range, but we see a 17% increase in FEV1, and we see other values increase as well. Mid-expiratory flow rate increases by a lot, and that increase in FEV1 crosses the 12% threshold, which is the American Thoracic Society threshold for a diagnosis of asthma or bronchoconstriction. Yeah, I would report this one exactly as we heard from the front row here. So mild bronchoconstriction at baseline, improvement after salbutamol, likely asthma. And then we come on to this next fancy test, and this is a very, very useful test. A provocation challenge. So you can see there in the middle zone that there are 4 different types of provocation challenge we can do. So you can ignore the saline because that's for something unrelated to exercise-induced asthma. Methacholine can be used to try to provoke asthma in someone in whom you suspect it. But then we're looking at exercise-induced shortness of breath. And so we look at, we can test after exercise. And I have to say, when I was in Alice Springs Hospital, when I didn't have access to a lung function lab, I'd do a baseline lung function, then I'd send the kid to the stairs and I'd get them up and down, up and down, up and down, or you can send them out to the park or send them out to the corridor to do some running, and then bring them back in and do a post-exercise challenge. Mannitol, though, in about the last 10 years has been a very welcome new addition, and by inhaling mannitol we can simulate the physiological changes of exercise in the airway, and it's sort of quicker to administer mannitol and then see what the response is. And so in a lung function lab, that's what we use. And so the first green arrow there, the top green arrow points to baseline FEV1, and the bottom arrow and the dotted line there points to the 15% threshold that we used for lung function decline in response to a challenge. So that's what we're looking for. We're looking for a decrease in FEV1 by that amount, and then we administer a bronchodilator and see if we can reverse that. And so let's look at this one, and this is someone from last week. We can see that when administered mannitol, and the dose of mannitol is not really important, but he actually got a response to quite a low dose of mannitol. And you can see that his FEV1 starts to fall, and then it plummets. And it goes down by about 20%, I think it was. 19% was his fall in FEV1. And then he was administered salbutamol, and up it came again. And so that's exercise-induced bronchoconstriction. That's diagnosis clinched. So I just want to go back to summarise what our role is as doctors looking after kids in this sort of situation. Importantly, we work out the cause of exercise-induced shortness of breath. We know that it's common. Is it pathological? Work that one out. Manage it. If it's asthma, treat for that. If it's something else, do something about that issue. But really importantly, get them back to their sport. Okay? What I actually say, and I have a little patter for this, is that if someone has a respiratory disease and they get shortness of breath in excess of what would be expected, that I want them to make that my problem. It's not their problem. They shouldn't actually be having to sit out their sport. And if you do that, it's highly rewarding. I would give all of you a medal if you're able to do that. And you can see just how proud these kids are to be given their various medals for participation in their sport. All right, I think you're equipped now to go forward and deal with some of these issues. We've got time to raise your finger if there are any questions.
Well, thank you very much, Rob, for reminding me of my exam when I had to interpret all those peak flow graphs and so forth. That took me back a little bit. We're looking for some questions, so if anyone would like to step up to the microphone, Mike, and Mike, can you go to the mic, please? And any questions, please tweet Ben at Simon_Ben or hashtag DFTB18.
Hi Rob, thanks for that. I'm a general paediatrician up in Toowoomba. I may have missed the point, but you mentioned that salbutamol as a prophylaxis or pre-exercise medication wasn't actually the best. Was it Montelukast that's actually better? Because I'd never even heard of or used or suggested Montelukast as a prophylaxis or pre-exercise medication.
No, that's it. So salbutamol is accessible and it works often, but no, it's not the most potent at dealing with exercise-induced asthma, and Montelukast is definitely more potent than salbutamol alone, and it's more potent than salmeterol. Salmeterol will often be in the armamentarium in someone's home. You know, kids have serotype, and we might suggest that they make sure that they don't miss it in the morning of sport. Sometimes that's enough, or they can have another dose before exercise. But almost every kid with asthma will have salbutamol accessible, and so that's why we recommend pre-medicating with that as a first line.
Okay, and is Montelukast, if they're already on that as their preventive therapy, is it something you can still give an additional dose for exercise, or is that
no, generally I wouldn't be recommending that. If I think back to the literature on it, the benefit of Montelukast is actually on that same day. So once someone is on Montelukast, then they're likely to have the benefit that they're going to get from it. There are different doses of Montelukast, and there may be an argument for trying a higher dose, but if that's not successful, then going back to their baseline is what I would do.
Okay, thanks.
That's okay.
Anyone, if you have any more questions, please feel free. We'll open the floor at the end of the topic. So please thank me, but most importantly, please thank Rob for his talk. Thank you so much, Rob.
Thank you.